Welcome to Wellness Fixes the Pod, a by Maven media production, where we believe you deserve real education from real experts delivered in a way you can actually use. I'm Dr. Kelsy Vick, your board-certified orthopedic doctor of physical therapy, and this podcast was built for the girl who is done feeling overwhelmed and frustrated by conflicting health noise and is ready for something she can actually trust. Every week, we have honest, science-backed conversations about your health, your hormones, your brain, your body, and everything in between. No fluff, no fear-mongering, just the truth. Because understanding your body is the most powerful thing you can do for yourself. A table full of experts built for the curious girl who wants the truth. So welcome. Your seat is waiting for you.
We always say, like, in aesthetics, the biggest giveaway of someone's age is not their face, it's their neck and their hands, because usually patients are really focused on treating their face and they forget those areas. And I always talk to my patients about risk versus benefits for doing these treatments, because this is not a haircut, right? It's a true medical procedure, and someone needs to be affected enough by their appearance or want to change their appearance enough that they're willing to take this risk. But all this is pointless if patients are not doing the basics. So collagen is degraded by UV exposure. The biggest mistake I see people making is that they come and they get their PRP microneedling facials, and then I see on their Instagram stories they are at the beach in full sun for the entire day, not applying sunscreen.
Have you ever wanted to ask an actual expert what Botox, lasers, and fillers actually do to your skin and why they work in the way that they do? I know I have, and it's the kind of answer that is very hard to find online, where the science usually gets flattened into before and after photos with an overlaying trending sound. So I brought in someone who truly understands not only how to get her patients results, but the science underlying those results. Claire is a board-certified nurse practitioner and a doctorally prepared clinician trained at Columbia University, where she also served on faculty. As a cosmetic injector, she is influenced by French beauty and wellness, and her methodology is built on a deep understanding of facial anatomy and evidence-based techniques. I am so excited to finally share this conversation with you guys and that we all get to learn from her today. Claire, welcome back to Wellness Fixes the Pod. What's actually happening within our skin as we age? Biologically, what are some of the drivers of the changes that we see in our skin throughout each decade?
The face ages just like the rest of the body. When we think about an aging female body, a lot of times we think about women who have osteoporosis and changes in the bone. And we have similar changes in the face where we have bone loss, we have changes in the fat pads at every level of the face, from the skin all the way deep down to the bone. And passing through ligaments and everything, there are changes that are happening into the face. So the ligaments relax, they don't provide as much support, the fat pads become smaller, so you have volume loss in the face. The bone, the apertures of where our eyes sit and the opening to our nose, those change. Patients will commonly get bone loss around the mental crease and right here in the piriform fossa and along the temple. Some of these changes are driven by the larger changes that are happening in the body. Hormonally, when estrogen drops, we notice that patients are at higher risk for osteopenia or osteoporosis. As estrogen drops, the skin quality changes, so collagen decreases with age, and I think also hormonally, it can drive a lot faster, those changes. So patients will start to notice creepy texture under their eyes. And then the repetitive movements of the muscles contracting in the face cause over time creasing in the skin as collagen and elastin decreases. So patients will notice that they develop lines across their forehead or lines in between their brows. And that is because there's repetitive movement folding that skin over and over, which causes a static line to form. So whereas when they were younger, those lines were only apparent during movement, so I call them dynamic wrinkles. They will start to develop static lines where those wrinkles are still present in the skin even after they've stopped making the expression due to the loss of collagen and elastin. And then our skin cells and our bodies are just not as good at doing what they used to at the same pace that they used to. So when we're young, we have beautiful, bouncy, glowy skin. And as we age, those skin cells that are rapidly turning over don't do so as quickly. So it can lead to things like dullness. We can see more signs, more evidence of photo aging and UV damage. So those can show up with things like sunspots. And I think those are the things that play the largest or most predominant role in the changes that happen to the aging face.
It's interesting that you talk about skin healing because I talk with patients a lot, and usually in their 30s, they're saying, like, I'm just noticing my body is not recovering well after exercise. And that's like their first sign of this. I'm not in my 20s anymore. My body isn't able to exercise and drink and sleep, stay out late with minimal sleep, all of these things. The first thing I noticed was my skin not healing as well. I kept telling my friends, I was like, I'd have this acne scar or something. And I was like, it just isn't healing as well. And I noticed it the most in my skin. That was like my very first thing where I was like, it wasn't the exercise, it wasn't the recovery, it wasn't the injuries. It was like my skin where I was like, it is not healing as quick as it once did.
It's wild the things we used to get away with. And it's interesting to see like what it is now, but obviously when I'm in my 40s and 50s, aging is real. And I went to school in New Orleans undergrad and would go out until God knows what hour of the night and drink and have a great time and wake up and go to organic chemistry at 8 a.m. in the morning and be absolutely fine. Now, if I have that second glass of wine at night, it trashes my entire next day. So I think, yeah, your body is not as good at doing what it normally does. Skin cell turnover slows, wound healing, it takes a little bit longer. There are other inflammatory processes that kind of get aggravated as you get older. And yeah, you're just overall not as good as you were when you were 10.
Are there any things that we can do at each decade to help support that collagen production, that hydration, that architecture of the face, like all of those signs that you were saying change as we age? Are there things that we can do with either fueling or supplementation or skincare, anything like that helps at each different decade, and even different treatments and procedures just broadly that we should be looking at for prevention and maintenance of some of those things as we age?
Yeah, so I always say an ounce of prevention is worth a pound of cure. And it really starts when you're young. That's when you have great collagen and you want to protect it. And so things that are really simple and effective are sun protection, like I've been saying like almost every second of any time we talk. Retinoids are really great when tolerated. A nice like antioxidant and something that keeps the barrier healthy. Your 20s are when prevention has the highest return. Daily sunscreen has randomized trial evidence for slowing photoaging. Retinoids improve photoaging by increasing epidermal turnover and supporting collagen biology. And so I think in your 20s, the most important thing is to just prioritize the things we have the most evidence for that are going to keep you the way that you are at that point in time. Really, nothing that's aggressive, just pretty conservative topicals. And if you're starting to see maybe like fine lines and wrinkles, you can think about doing a conservative neuromodulator. Although I usually say if the lines are not static, that means they're just there when you're not expressing. They're dynamic, you have good collagen, like it's not necessarily something that I would run to go do in terms of procedures. For 30s, I think the most important thing is collagen banking. So you can do things like maintenance neuromodulators like Botox and Dysport, but like at that point, even if you're really judicious about sunscreen, like you may have some pigment, whether it's related to sun exposure or genetically or hormonally driven. So priorities, I think, shift, and then you can maybe add in a little bit of Botox and Dysport really just to prevent fine lines and wrinkles from forming and becoming static, and adding like a little IPL or vascular laser to address any type of redness or pigment is really nice. Maybe considering small volume filler if there's any type of anatomy that's changed, but I usually don't have patients run to chase those types of things. And then you have to keep in mind your 30s are when most women are either planning pregnancy. A lot of women get pregnant in their late 20s, but I think women are starting to get pregnant later. And you have to keep in mind, like, all of these things have to be safe during pregnancy and postpartum. So really tailoring the approach to be appropriate for the stage of life that a woman is in. And then your 40s are really the time, I think, when you start to see structural changes and skin quality really changing. That's that perimenopausal time. And so this is when patients often say, I look tired, even if they've slept, or there's just this not so tangible thing. They can't put their finger on it, but there's a change and they want to improve it. That's when I think neuromodulators to really treat the way that the muscles pull are very effective. Lower face Botox, especially in the platysma, will help with releasing any downward pull and lift the face up a little bit without needing to necessarily do filler. There are patients that will see real signs of bony changes in their face, although it's a little bit early in your 40s, but mid to late 40s, patients will see their piriform starts to hollow out. There's usually some bone loss on the chin here. The temples become a little bit sunken in. And so those are areas that can be considered for volume repletion. And I think it certainly makes patients feel good. It restores a little bit of the support that they normally had in their face, and it's a really effective treatment to use either a biostimulator or an HA-based filler to treat those areas. And then at that point in time, patients tend to start getting a little bit more aggressive with their treatments. They have a more serious pigment strategy. They're using a tinted SPF. They're probably using a little bit higher dose of a retinoid to really get the skin cells turning over, and then incorporating in whatever topicals are targeted for them. So azelaic acid or hydroquinone when appropriate, and like carefully selected and very targeted lasers. And that's, like I said, the point in time when you really have to think about how perimenopause is changing the skin, and estrogen is really one of those things I think is biologically relevant for aesthetics. And women will see like real changes in the quality of their skin, like crepiness and dryness, and doing some treatments to address that can be really helpful. And then 50s and beyond is when I try to get patients to embrace the aging process a little bit, right? We don't want to look like we're 20 when we're in our 50s, but tackling some of the age-related changes to get hydration back in the skin is really nice. Obviously, the mainstay of every decade is going to be SPF and still using a retinoid, but they can use a more aggressive resurfacing laser if it's appropriate. Things like CO2 lasers that ablate the top layer of the skin will really lift off pigment. It's aggressive and there's significant downtime, but it does wonders for like fine lines and wrinkles and pigment. And then still at that point in time, I like incorporating a little bit of filler biostimulator for patients and treating areas not just like the face, but really the neck, sometimes even the hands and other areas on the body that show signs of aging. So we always say, like, in aesthetics, the biggest giveaway of someone's age is not their face, it's their neck and their hands, because usually patients are really focused on treating their face and they forget those areas. And then at every point in time in the decade, or at every point in time in each decade, you should be having an annual full skin exam. That means you're completely naked, head to toe, in a room with a dermatologist or someone who is very skilled at evaluating the skin and looking at any new lesions or any enlarging pigment or anything that could be a suspicious lesion, to make sure that you're staying healthy and catching basal cells or any type of melanomas or things that are going to eventually turn into skin cancer, precancerous lesions. So that's what I would give for guidance at each decade.
Let's zoom in a little bit on, you mentioned neuromodulators and you use that term. Can you describe what they are, what they do, what might be like the terminologies that we know for neuromodulators, and how they can be used like preventatively and reactively? I think you've talked about both.
Yeah, so neuromodulators is like the big umbrella for things that most patients have heard of, are called Botox, Dysport, Xeomin. There are lots of them on the market, and they essentially, patients think of them or use them to treat wrinkles, but what they do is actually treat the muscle, and it prevents the muscle from either pulling or creasing the skin in a certain direction. And by knocking out or causing a little bit of paralysis in that area that maybe they have a complaint about, they smooth out the area. Botox, Dysport, all of these neuromodulators actually modulate the signal that's going to the nerve to tell it to contract. So that's why I call it a neuromodulator. So not all injectables are neuromodulators. Neuromodulators are your Botox, Dysport, Xeomin, if that makes sense. And the two that are most common that most people think about are like Botox and Dysport. They're very well studied. I will say that Botox has broader published evidence overall, largely because it has more FDA approved indications and it's been studied like extensively across aesthetics, but also for treatment of like migraine headaches and hyperhidrosis, spasticity, like in MS. It's used for, I think, bladder dysfunction. It can be injected to treat palatal myoclonus. There's so many therapeutic uses, but obviously specific to me, I use it to diminish the strength or paralyze a portion of a muscle that is either, for me, pulling down, for my patients, pulling down in a direction that we don't want. Most patients want to feel more lifted for aesthetic treatment, or to smooth out a wrinkle. So like when the muscles are, say for the frontalis, when you raise your eyebrows upwards, it causes a crease in the skin. So when you place Botox in an area that's pulling up and creasing the skin, it doesn't pull up anymore and it smooths out the skin. So yeah, you can use it preventatively. And I see that for patients that are like on a Zoom and they say whenever I'm like on Zoom, I'm scrunching my face and I see these 11 lines and they may not have those like clear demarcated areas, and we can use it preventatively to make sure that they don't develop those indentations or those wrinkles there. And then obviously whenever I see static lines, that means somebody comes into the office and they're just sitting there and they're not making an expression and they just have these lines that are going across their forehead. We can treat them with a little bit of Botox or Dysport neuromodulator so that they can either be smoother or completely go away. And I usually will tell patients who have static lines on their face, think about these lines as wrinkles in a bed sheet. You've had a bed sheet that's been folded up in your closet for months on end, and now you're finally pulling it out to put it on to the bed. And you can't expect that those wrinkles are going to be smoothed out the second that you pull out the sheet. It really takes a little bit of time of not making that repetitive movement, not creasing the bed sheet, and having it stretched out over the mattress for those wrinkles to smooth out, but eventually they do. So that's like that's my consult for when I talk to patients about treating dynamic versus static lines.
And for something like forehead lines, and then you mentioned the platysma, where in my head that seems a little bit more of a dramatic, gravity's like pulling on this area a little bit more than just like your forehead raising up and the lines there. Is there different levels of effectiveness depending on the area you're treating, different dosages, different lengths of time that that neuromodular might stay effective, wear off quicker? Does it wear off quicker in certain areas? Is there basically differences in where and how you use it across the whole face?
Yeah, so those are really great questions, and pretty much yes to all of them. The areas that tend to wear off quickest are the areas that get used the most and the areas that have the lowest dosing. So, for example, a lip flip, which is commonly used to paralyze a portion of the orbicularis oris here and evert the tissue on the top lip to show more. Your mouth is constantly moving. And because of your need to speak and kiss and drink and sip soup from a spoon, we don't want to over paralyze that muscle. So it's a muscle that gets a very low dose of neuromodulator, and it's going to be in an area that's super active. So it lasts a very short amount of time. Whereas when we do much higher doses in muscles like, say, the masseters, I find that tends to stick around for a little bit longer. I have some patients that say that they feel the effects for almost 6 months, which is not necessarily in line with what the makers say. They say that Botox is supposed to last 12 weeks, or all of the clinical studies looked at the ramp up period, how long the effects last, and when patients reported seeing wrinkles again. But I think because the doses are much higher, you're getting a more sustained paralysis and you're actually weakening the muscle so that it's not able to be used as strong as it would baseline. So maybe some of those effects are prolonged, not necessarily because the paralysis is maintained, but you've actually physically shrunk the muscle a little bit by not using it. And so you're not able to grind or bite down as hard. So yeah, I think the length of time and how paralyzed the area is really a function of how much movement that muscle has and the dosing that you're using to treat it, among some other things. But yeah.
What about other injectables? Do you have other favorite injectables that you get a lot of bang for your buck with your clients? And what are they and what would you use those for?
So there are lots of injectables on the market. Most commonly used are HA-based injectables. Those are hyaluronic acid gels. HA is a water binding molecule that is naturally present in your skin and connective tissue. And when you talk about HA or filler, hyaluronic acid gels and fillers, they're all pretty different. They have different firmness, different elasticity, the cohesivity of the gel, and what they call the lifting capacity of the gel is all very different. I would say that those are like one of the main things that I have in my tool belt, other than biostimulatory injectables. And those are things like Radius or Sculptra. So fillers should be placed according to the anatomy. So for deep structural support, like in the cheek and the chin and the jawline, and that can be to give someone an anatomy that they don't naturally have. So someone who may be contemplating a chin augmentation, that they're a little bit recessed and their chin falls behind the area where they would. Maybe the nose is a thing that projects the most maximally. Those are patients that come to me a lot of the time and want projection in their chin and improvement of their appearance from the profile. And HA fillers are really effective, especially things like Voluma are extremely effective at giving that type of anatomy to a patient who doesn't necessarily have it. I like them, and I choose to use fillers in my practice that are reversible. And that's for two reasons. One is an aesthetic one, and the other is a safety reason. And it's mainly because these are aesthetic things. As aligned as we can be, and as good as I am at giving someone something, there's something nice about being able to reverse it, whether that's a patient just decides, I don't want this in my face anymore for whatever personal reasons, or maybe somebody says, I tried it, and maybe I'm glad I tried it. I thought maybe if I like this, I would get a chin implant, but maybe this is not the right thing for me aesthetically, and you can dissolve it. So I think aesthetically, that's really nice. And the other reason is because with any of these HA-based fillers, they're meant to be injected not into the vasculature. So either on periosteum, above periosteum, or within the tissue to augment it. But if there is a rare complication called vascular occlusion. If the filler is injected into a blood vessel, it can block or occlude the flow through that vessel. And that can lead to some very serious problems that require urgent or emergent treatment. So obviously, when you don't get blood flow to the tissue, it can cause the tissue to die or necrose. So usually these things present pretty immediately, and you need an enzyme called hyaluronidase to break down the HA-based filler and restore blood flow to the area. And I always talk to my patients about risk versus benefits for doing these treatments, because this is not a haircut, right? It's a true medical procedure, and someone needs to be affected enough by their appearance or want to change their appearance enough that they're willing to take this risk. Even though it's extremely rare, I've never in my practice, and it's just a matter of time because if you've been doing it long enough, it will happen, but I've never personally had an occlusion in my practice, or for me personally, but I have assisted in dissolving 2 occlusions. And so, it can be scary for patients and for providers. I think the thing that gives me comfort is knowing that there is something that you can do. It is reversible and it is treatable, and there is an algorithm to manage these complications. So that's why I personally choose to use reversible fillers in my practice. So they can be used for obviously treating deep structural support, like I said, the cheek, the chin, the jawline, and aging the piriform fossa and temporal hollowing, and then nasolabial folds for more soft tissue blending and helping blend out some of this line that you see when the cheek descends, or areas like the pre-gel sulcus, where you can start to see a little bit of gelling and an indentation that comes in before the chin just to give a smoother jawline. Or for things like superficial refinement in the lips, for fine lines and wrinkles somewhere that are pretty etched in, they can be really powerful tools. I always say the key is that fillers should not really simply chase a crease. Like a nasolabial fold, for example, may be caused by cheek descent or mid-face volume loss. So it's really important to address the reason why that crease is occurring. And only filling a fold or an area where there is a shadow can make someone look really heavy and unnatural. So yeah, those are, in my opinion, the areas that are best suited for using filler.
I've heard of filler shifting. What is that happening? I know some people are very cautious about under eye filler and things like that where it can shift. What is actually happening with that? Is that HA based filler moving somewhere else? Can you describe that a little bit to me?
Yeah, so filler can migrate. I tend to feel that the fillers that migrate or appear migrated, whether it's a filler or something else that's happening, are the ones that draw in the most water, are injected the most superficially, and are the thinnest. That's probably more of my personal opinion than there's any real guidance or real evidence to guide me saying that. But when you classically think of like pore filler, I think everybody gets this like image in their head of, I think like Jennifer Aniston or one of the Kardashian sisters. I can't remember her name. But like this area right around the tear trough that's like really bulky and large and looks just funny and strange. And that's more likely than not because filler was placed there. It may have looked incredible that the day that it was placed or even for weeks after that, but shifts in fluid volume can change how filler appears. So that filler may provide great support for her under eyes right after it's injected, but if she has seasonal allergies, she may be drawing more water to the area. If the product spreads a tiny bit, then it's going to attract water to that area and make it more apparent. And the most common place that I see this is like the lips, right? Especially when lips are overfilled and the anatomical boundaries are not respected, you get migration of filler outside of the border of the lip, which gives this really unnatural kind of shelved appearance and projection. And it's worsened when a patient will have a meal that is salty or they just have a little bit more fluid volume. I'm pretty sure that my filler just felt a little heavier to me when I was pregnant just because I was holding on to so much fluid. So the real shifts that happen in the body can make filler more apparent whether or not it's migrated. So if your filler is like in your lip but you're pulling more water to that area, you may see some prominence around the outside of the lip. So I would say yes and no. Is it always migration that people are saying when filler looks bad? Not necessarily. Sometimes it's just how the product is holding on to water, and smoothing it out or dissolving it a tiny bit, not necessarily getting rid of all of it, can make it appear better. But yeah, migration is a thing. I would say like overwhelmingly, if you respect the boundaries, you're not placing excessive amounts of filler in the area and you're respecting the anatomical boundaries, filler migration is pretty uncommon, but there are some things that can make it happen more than other things.
That makes total sense, especially with the fluid changes, especially throughout, like you said, pregnancy and hydration as we age. All of those things affect it. Seasonal allergies, even. I never even thought about all of those things
Oh yeah.
affecting how
That's
it
like one of
looks.
my big things that I screen for in patients is I get patients who come in. I think under eye filler is overdone in general. There are other things that you can do to help treat that area to make it appear more rested, like your under eyes. Just treating the medial cheek will give support to the under eye. Going and just putting filler in there is never like the first thing that I run to. But I won't inject someone if they tell me I get really bad seasonal allergies, because more likely, especially like itchy, swollen eyes, because it may look good when we place it in the winter time, but come spring, their eyes like blow up and it can be a nightmare to manage. In the right person, in the right candidate, it can be a very powerful tool and it can look great, but in the wrong person, it can look really terrible.
Can you talk a little bit about the difference between HA and something like Sculptra? I think you categorize Sculptra under biostimulator. How are
Mhm.
those different? How do they work within our skin differently?
So yeah, so HA fillers, you can see immediately when they're injected. They are a gel that is meant to volumize. Sculptra and biostimulants, Sculptra is PLLA, so it's reconstituted in saline and it's injected, and it relies on the body's ability to be stimulated to produce collagen. So you don't necessarily get an immediate result from Sculptra or any of these biostimulators. Some of them are like Radius, it has a gel carrier where you can see some result from it, but that gel carrier tends to get absorbed around 3 months. Like it peters on out like around 3 months post-injection. But the main difference is that one is putting in a naturally occurring HA is a naturally occurring thing in your body and volumizing it immediately. And the other one, apart from what with the saline, when it's reconstituted, you don't get an immediate result. It relies on your body stimulating collagen and elastin to either improve the quality of the skin or to volumize an area. And I believe that Sculptra was originally developed to treat HIV patients a long time ago who had gauntness in their face and they wanted to revolumize the area, and it was incredibly effective. And then now it's been, I think the dilution has changed a little bit in the amount that we do, but now it's really used for more cosmetic aesthetic purposes. And it's a really powerful tool, but it relies, like I said, on your body producing that collagen and filling or improving the area over time.
So switching gears a little bit to lasers and different like energy-based treatments, describe some of your favorite lasers and what you might use them for in clinical practice and who they're best for.
So lasers are just a huge area, and I'm going to try to do it justice in just a small amount of time and simplify it, because when I started learning about lasers, I got very overwhelmed. There's so many lasers on the market, and it's really hard to understand who is best suited for them and what they're most effective for. So I like to think of lasers as like a very specific flashlight. Different lasers are attracted to different things in the skin, be that brown for pigment and melanin, red to treat things like blood vessels or redness, water in the skin, which is when you use a laser for resurfacing and wrinkles and texture, that's what it's attracted to. And heat will also cause collagen stimulation, which a lot of lasers deliver heat to the skin or right below the skin. So the key is really choosing the right laser for the right target. So for things like your brown pigment, those are lasers like Pico lasers or Q-switch lasers. 1927 fractional lasers can be good for it, or even IPL and BBL, which is, I don't believe, a true laser. I think it's actually just light. That's used to treat some browns and reds. And they're good, like I said, for sunspots, freckles, lentogens, sometimes post-inflammatory hyperpigmentation. And like the Picos and the Q-switch can pull out tattoo pigment, which is the primary laser that's used in all of these tattoo removal clinics. So think of the pigment like browns, and this is the best lasers to treat them. They break up the pigment and your body clears out that pigment either by taking it out internally or it coming to the surface and flaking off. The second category of lasers treat the reds in the skin, and those are things that are caused by like rosacea or broken capillaries, those little like telangiectasias that people get around the nose, even like cherry angiomas, those like little red dots. I got them all over my body when I was pregnant. Some red scars, facial veins can be treated with pulse dye lasers, vascular lasers like B-beam and XLV, and they target specifically blood cells and help collapse them or reduce them. And then there are the lasers that are meant to treat things like texture and pores and fine lines and scars. And these lasers work by making tiny controlled injuries in the skin so that the skin repairs itself with new collagen. And there are two kind of broad types of these lasers. They're non-ablative, so it spares the surface of the skin, and ablative, which means it takes the surface level of the skin off. And the non-ablative lasers are things that a lot of people have heard of. They are like your Moxie laser, Clear and Brilliant, Fraxel. These heat the skin without fully removing the surface, and they're great for treating mild texture and pigment and early aging. They have like low to moderate downtime depending on the settings. And then your ablative fractional lasers are like your CO2 lasers or your erbium lag lasers. And these remove those tiny columns of skin, and they're incredibly effective for deeper wrinkles, acne scarring, more severe sun damage, and like just a really more dramatic kind of resurfacing effect. So because they're more effective, there's more downtime, and because there's more downtime, there's more risk. So risks are things like hyperpigmentation, infections, and so you really need to select patients carefully before you just use this laser on anyone. Fractional lasers induce collagen remodeling over time, and that usually peaks around 3 months post-treatment. And finally, I will say that fractional resurface lasers also have some evidence for reducing non-melanoma skin cancers and high-risk like photo damage patients. So while a lot of patients are doing these to improve the appearance of their skin, there are really some nice health benefits for them.
I think that was the perfect sort of like overarching description because it sounds like different wavelengths affect different parts of the skin and different depths of the skin and different colors that you might find on the skin, whether it's like you said, the brown or the reds, the hyperpigmentation, things like that. And I know it can get very confusing, but I've heard all of these terms like BBL and Moxie and all sorts of these different energy-based treatments or light-based treatments. So I think it was a very helpful sort of like umbrella perspective of them all. The other thing I had questions on was PRP and microneedling. Where does that all fall within the realm of aesthetic dermatology and just things that you can do to improve your skin?
Yeah, I'm sure PRP, like being injected for joints, I think, is used in other places in the body. I think there was like some weird, not weird, I shouldn't say weird. There were some trials maybe where they were looking at for ovarian, like anti-aging purposes, but it's used like in other places in the body, which I find really interesting. We more commonly use it in hair restoration and for PRP microneedling to help stimulate collagen and elastin. I think there is some evidence out there to support its use, but I think the protocols for it are a little bit lacking personally. I think there's more evidence there for hair restoration, both with microneedling and PRP injections, but there's some data to support that it helps improve the results of microneedling. Microneedling works similarly to lasers, that it's creating these columns or these areas of trauma within the skin. And the hope is that the body tries to heal that area and fill it in with new collagen and elastin. So it remodels things over time. And then I explain to patients that by putting PRP in there, in theory, that you're putting in all of the growth factors or platelet-rich fibrin or platelet-rich plasma, whatever is being used. It is meant to put in growth factors so that it stimulates collagen and elastin a little bit better. I still think there's a lot of work to be done in that area just to standardize protocols to have the best outcomes. But all of this is pointless, in my opinion, if patients are not doing the basics. So collagen is degraded by UV exposure. The biggest mistake I see people making is that they come and they get their PRP microneedling facials, and then I see on their Instagram stories they are at the beach in full sun for the entire day, not applying sunscreen, and it kills me inside, because what's the point of doing all of these things if you're just going to go then do the things that degrade your collagen? So I think they're nice. They're a nice tool to help support and slow the aging process. And I think in the next coming years, hopefully we will see a lot better evidence for them in terms of the protocols, but they're just one of the tools in your tool belt.
What about any sort of non-invasive treatments? I'm even thinking something like, I don't know if this is considered non-invasive, but like gua sha and dermaplaning. Where do those fit into things? Are those overhyped, or is there some merit to actually some of those non-invasive treatments or any other non-invasive ones?
Listen, I think for the most part, they do very little harm. If it's something that you enjoy to do at home, by all means do it. I think supporting the lymphatic system is incredibly helpful. It's something that you have to be pretty consistent with and make a part of your lifestyle if you like the results from it. I used to work with Shelly Marshall. She's Beauty Shamans on Instagram, and she used to inject. She said she was a person who started doing my Botox when we worked together as nurses, and she stepped away from injectables and really went full in on these holistic methods to treat congestion in the skin like acne and to help all the different layers of the skin. And she primarily does that through things like gua sha. And I think there's a lot of mixed information out there about it, but from a scientific standpoint, you'll always benefit from supporting your lymphatic system. So I don't think there's any downsides to it. And if somebody is seeing benefits from it, I tell the patients to keep doing it, with the exception that patients who do have facial fillers need to be careful about really not doing anything super aggressive to manipulate the tissues of the face if we've injected filler in that area. So that's my kind of one caveat for it. Dermaplaning is not, I mean, it's nice. It's a nice treatment to lift off some dead skin cells off of the very top surface of the skin, and it can shave off that peach fuzz, which is nice. It helps makeup lay a little bit more smoothly. So I think if you enjoy the results from it, definitely do it. There's low risk to it, with the exception that I think Some patients may get congested, get some skin congestion and breakouts from dermaplaning just because it can cut the hairs, and then those can get a little bit stuck underneath the skin, or it can cause these superficial kind of openings in the surface of the skin that can make patients break out. So, see somebody who's qualified to do it, or if you're doing it at home, really understand the process to do it. I tend to not advocate too much for doing things at home that are borderline medical procedures just because of the risk for infection. But I say there are like few downsides to it if patients want to try it.
And then lastly, I know we've talked a lot about face, a little bit on the neck, and you mentioned the hands, but where do you see this field going in the future? Is there anything that you're like, okay, I have a feeling this is going to be even trendier in the future? Or I'm thinking one of my goals in 2026 was taking better care of my full body skin. I feel like I've had a pretty good skincare routine in the face, and I prioritize a lot of different things for the face, but I was like, the skin's the largest organ in the body, and I'm like prioritizing maybe 5% of it. I'm not putting that focus on the rest of my body. So in my head, I'm like, I selfishly wonder, are any of these things that we talked about today going to apply, do you think, in the future to your full body skin? Or what are some of the other things that we can watch out for in this realm that you think are just now up and coming?
Okay, so yes, to full body skin health. I think this patients already understand face skincare for the most part. I'm not doing as much basic level educating when patients come into the office about like skincare and what they should be using. But like the future, I think really is the neck, the chest, the hands, arms, knees. Like patients are starting to notice their knees. And like postpartum for me, my abdomen was something that I really started to think about, and especially with the use of GLP-1s, I think post weight loss skin quality, and the same biology that applies to your face applies to the rest of the body. So I think we'll be seeing a focus on other areas come up a lot more. I think patients are also very interested in, and I think the field is shifting towards more biostimulatory treatments. There's really a focus on less filling and more restoring tissue behavior and stimulating collagen and elastin and helping along wound healing, because all of these treatments that function by creating a wound in the skin, whether that's a laser or microneedling, are only as effective as how you heal. And so if you're not babying the skin and really guiding the skin to heal truly better than what it was before, you're doing yourself a disservice and you're not reaping all of the benefits of that treatment. And I think we'll see patients really trying to manage inflammation, getting inflammatory processes under control, because you can see the effects of that in the skin. I also think there will probably be a shift towards better skin imaging diagnostics, whether that's like just plain photography in the office, but the use of ultrasounds in office to make treatment safer. So imaging blood vessels so that when we're injecting, we know that we're in a safe territory, and also to aid in the reversal and management of complications. I think there's still a lot that can be done to improve it. And when it comes to medical things, I used to work in radiology a long time ago, but if I was doing a paracentesis or a thoracentesis to drain fluid off of somebody because they had an accumulation in the abdomen, yeah, you can do that quote unquote blind, where you place a needle in and drain the fluid, but there are blood vessels and bowel and all sorts of things that are in the way that by just doing it blind, you don't necessarily see. And I think in aesthetics, we function by knowing the anatomy, but going in blind without using any diagnostic tools. And I think because now in hospital, you're imaging with ultrasound before you stick someone to make sure that you're in the right area, you're not going to nick bowel, like for paracentesis. And I think that will be a shift that slowly makes its way into aesthetics. For whatever reason, I think because these are aesthetic medical procedures, there hasn't been that drive to do it. And I hope for me as a provider, we now like at my practice have an ultrasound in office, but I hope that will be a shift for the industry. And then lastly, probably just like a less one face fits all. I think aesthetic medicine in general is moving away from just doing the same thing to every patient and shifting towards really respecting every individual's anatomy ethnicity, obviously sex, because male proportions are very different than female proportions, but a lot of males are being feminized because they needed volume repletion in their cheeks, but injectors were giving them like a female cheek. And I think there will be more respect for hormonal state, whether that's around the time that women are pregnant, because there are a lot of real changes that happen around that time, and then perimenopause, and then obviously weight changes with all of these GLP-1s. I think treatments are going to be a lot more tailored to all of the fluctuations that are happening because of either the life cycle or the stage that people are at, or the lifestyle that people are adopting. Everybody is now like drinking way less alcohol and hopefully eating healthier and maintaining better weights.
I think that individualized nature of how someone is looking and not having this copy paste for every patient also feeds back into that imaging and that being on the forefront of imaging, because it's like the more you're able to see and actually tell, the more individualized you're going to be able to make some of those treatments, probably, is my assumption too.
Absolutely. Yeah. And I always say when you go to inject someone, you can be the most trained plastic surgeon and have dissected the face and know all of the planes and know exactly where everything is based off of your training, but anatomical variants are real. That artery 95% of the time runs in this direction, in this plane, at this level, but in another percentage of patients, it does not. And so when you inject and you don't use image-based guidance, you are making a statistical decision on minimizing the risk. And I think those tools will help providers and patients have better results. And obviously, the last thing is that there's going to be this strong shift, I think, for me personally, not making patients look wildly different. Like that's always been my philosophy. My approach is really to understand which layer is aging and help that along, and not necessarily change the way somebody looks drastically. So the best aesthetic work is like not about chasing trends. It's about preserving patients' identity while improving or restoring some aspect of the age that has been affected by the aging process, whether that's skin quality, proportions, or like the way that light reflects off of the face.
I had a professor who once described certain changes, bony changes that happen within our knees and joints, like you might have degenerative discs or arthritis, whatever. He described them like laugh lines on the face. It's a sign of a life well lived. He'd say that. And I feel, like you said, a lot of people are just starting to embrace that aging process and trying to maintain a lot of the things that make them who they are. And like you said, not trying to have a 50-year-old look like a 20-year-old, but actually embracing who they are at that stage of life. And I really am grateful to be in this time where I'm noticing all of these women who are a few decades older than me starting to embrace that.
Yeah, my husband and I just took a trip to Japan recently. We had a conference in Singapore, and we decided to make a big trip out of it. And one of the philosophies in Japanese culture is something called wabi-sabi, and it really touched me. It has to do with really the appearance of things and how they look from being used. So like even a dish that has fallen and broken that's in piece back together, it's like very honored to see all of the lines and the imperfections in that item, because it gives meaning and history to that thing. That a bouquet is not like perfectly round and every flower is at the exact same spot on the left and right, but really to embrace nature and the way that nature made us, which can seem a little bit counterintuitive in the field that I'm in, right? Your patients don't want to embrace their wrinkles, but at the same time, like there are certain things that are very defining to patients' faces. I always say like each individual is uniquely beautiful in their own way, and my job is really to highlight that and to do that honor and not remove it and change it. So, and that goes for everything. My husband has this gap between his teeth, and I think it's the most attractive thing about him. I love it. And the dentist, every time she sees him, is, hey, do you want us to do Invisalign and close that gap? So, a little part of what I do is also giving patients the confidence to embrace the things that make them uniquely them and find beauty in that.
I think that's the perfect place to end. I learned so much today. I had so many questions coming in, and I had told you I was very excited to learn all of this because you hear all of these key terms and phrases. I'm like, okay, but I need to understand how they actually affect the skin. And it's not just as easy as we think it is. The skin is a very complex organ. So I appreciate you coming on, chatting through all of it today, answering all of my possibly elementary questions, but I learned so much and I know everyone else did too. So I will leave all of Claire's links below if you happen to be in NYC and want to book with her at Vollure Medical, or just follow her on social media. I learned so much from her there too. I'll see you guys again on the next episode of Wellness Fixes the Pod.